Hello and welcome everyone to today's Spotlight Series session, Better Home Care for Older Adults and Caregivers. Please note that this session is being recorded. We are pleased to offer French simultaneous interpretation for this session. If you wish to hear the voice of the interpreter, please select French from the interpretation menu at the bottom of your screen. English participants may choose to view the auto-generated live transcripts or subtitles throughout today's session by clicking CC Show Captions button from the Zoom menu at the bottom of your screen. Auto-generated translated French captions are also available for this session. To access the translated captions, select the up arrow on the CC Captions button and select French from the Translate to menu. If at any point you need support at any time during this webinar, you can reach out to one of our tech support using the chat feature. So good morning, afternoon again. My name is Tanya McDonald. I am Director of Strategic Initiatives and Engagement at Healthcare Excellence Canada, and I'm pleased to be your host today. Healthcare Excellence Canada, or HEC, is a new organization launched in 2021 with a relentless focus on improving healthcare with and for everyone in Canada. Our Spotlight series is an opportunity to have a focused, constructive discussion and explore solutions to make improvements last as we work together to shape the future of quality and safety in healthcare across the country. Today's episode is titled Better Home Care for Older Adults and Caregivers. Before we start, I'd like to acknowledge that I am hosting this webinar today from the unceded, unsurrendered territory of the Algonquin Anishinaabe people, known as Ottawa, Ontario. I'm grateful to live in this beautiful place near the Ottawa River and have the opportunity to enjoy the nature that surrounds me on a daily basis. We invite you to share your questions and comments during today's webinar using our chat box in either English or French. We'll do our best to get to them all, and we encourage all of you to share and respond to questions in the chat box as you wish and as we go along. As we jump into the webinar, we want to ensure that we are setting up an environment that is psychologically safe and recognize that these topics may be difficult for some. We've added some mental health resources in the chat. Keep them around. You or someone you know may be struggling, and it's always easier to reach out when you know where to go. As I introduce our guest speakers, if you haven't already done so, I'd invite our participants to introduce yourselves in the chat box and provide a land acknowledgement and preferred pronouns if you feel comfortable to do so. So joining us today are Janice Keith, who is full professor and chair of the Department of Family Studies and Gerontology at Mount St. Vincent University. Sorry, Janice. Our next panelist is James Gennaro, Director of Policy and Government Relations at the Canadian Centre for Caregiving Excellence. Next, we have Paul Holyoke, who is the Vice President, Research and Innovation at SC Health Research Centre. And also from SC Health, Jane Vox, Social Worker and Caregiver Program Manager. So welcome to you all. So I think we'll dive right into the conversation. And so the first question is for you, Janice. So what is the need for improved home care for older adults in Canada today? Janice is searching for her mute. There you go.
Okay. Did you want us to introduce ourselves first or just go right into it?
I mean, you can say a little bit about yourself and then
okay.
You can go right into it.
Sure. So as Tanya said, I'm at Mount St. Vincent University and have been working in the field of home care for quite a long time. I actually started my career in public home care as a care coordinator assessor. So went on to do PhD, mainly interested in caregiving, but also in the system level and the worker level, the home support worker. So in terms of what needs improvement, I think we all could agree that we definitely need to have greater consistency and competencies of our workers, that they have some standardized training, but mainly the consistency for the client in terms of having similar workers coming on a daily basis and not having a rotating door of individuals. We certainly also need to have navigation off the system. It's very complex as you go in and out of different areas, be that hospital, home care, need for other allied health supports, etc. And then the need for more community-based options. So more in a localized area. I think part of the pandemic, in fact, highlighted the fact that many people became very, very isolated. And so we need to think about not just delivering services in large centralized areas, but how do we get that to the local community halls in our provinces so that people can become more engaged and participatory. And then, finally, I mean, I know we're going to talk about this. We have experts on the panel like Jane, but really a focus on support for caregivers, recognition that caregivers are not the same. Their needs are not the same. They actually have a whole variety of different needs, and it depends. Of course, the clients aren't the same. Some clients in home care are more maintenance home. They need a support, but it's maybe at a more lower level than some others that have very, very high needs. And not to make the assumption that all clients have caregivers or have caregivers who are willing or able to participate in the kind of care. So we have to get away from some of these assumptions that family's going to be there for someone, because it's not always possible. And so we really do need to bring all of that together. So I think I'll stop there and let my fellow colleagues jump in.
Sure. And so Paul's lifted up his hand, so I'll go to you, Paul, next, and also provide just a brief introduction as well and your interest to the topic that we were discussing today. Oh, and Paul, you'll have to unmute yourself. There you go.
There you go. So thanks very much, Tanya and Janice. Echo a lot of what you've said. I'm the VP of Research and Innovation at SE Health. And SE Health is a social enterprise, not-for-profit, primarily located in home care, but involved in other parts of the healthcare system. So as an applied researcher at SE Health, we see some of the issues that arise in home care and are able to sort of look at them holistically. And one thing that we've noticed in thinking about how could home care be improved, one of the things that we've noticed is that a lot of the talk about home care is that it's the cheaper option. And we think that might be the wrong starting point, because it's premised on a lot of unmet needs. We know that across the country, people who are receiving home care have unmet needs, 30–40% of people. And the other thing, sort of to pick up on Janice's point, a lot of that cheaper option talk comes from the over-reliance on caregivers. Caregivers are in the home, so we can assume that care is being done and it's free from a public payer perspective. So we started from that premise and looked at the experience of 200,000 or so Ontario home care recipients and started with their needs rather than looking at what the system was providing them. And we found a whole lot of unmet needs. And what we did then is asked caregivers, older adults, care providers, what would actually meet those needs? And I think what we found, a couple of things that are relevant to our conversation here, is that there are lots of needs that need to be met in different ways. And to pick up on Janice's point, caregivers need to be supported. They are members of the care team, or in fact, healthcare professionals are part of the caregiver's care team, taking care of the person in the home. And so we, in our development of care packages for the various groups of people we identified, we heard loud and clear that support for a caregiver had to be respite, time to take over some of the tasks that are normally assigned to caregivers, like organizing trips out and so on. Part of that would be done by a team that would support the caregiver and the person living at home. So lots of interesting observations, and I'll pass it on to anybody else who has some comments, but there's loads of improvement in home care for sure.
So maybe, Jane, not to call you out, but I will, because we are talking about the caregiver piece. So wondering if you'd like to weigh in as well and provide a short introduction as well.
Yeah, sure. Well, I guess for about 14 years, I was a direct service social worker working with clients and families in their home who were receiving home care. And now I'm working kind of almost exclusively with caregivers. I mean, I just want to say yes to everything that Janice and Paul have said. One thing I noticed, and for sure, like out of it, for the entire 14 years, the biggest complaint from clients and families was the lack of continuity. So this is a long-standing problem with really having a kind of a stable home care workforce, I would say. So that's just such a constant complaint. And the other thing that just jumps out at me, that you can't do a one size fits all kind of solution for caregivers. They're, like Paul was mentioning, like their needs are so nuanced. The client situations and caregiver situations really require, I think, one-on-one attention, because the needs are so wide and varied. You can't do this one size fits all for caregivers. I'll stop myself now.
And then James, I'll pass it over to you, absolutely, to wrap up this question for us. And also please provide a short introduction.
Sure. Thank you, Tanya. So it's an excellent question to get us started, and I'll just echo what my co-panelists said on this. Top-notch and absolute thumbs up to all that. From where I am at the Canadian Centre for Caregiving Excellence, where our approach to this is to look at this as sort of two ends of one equation. You've got caregivers, family, friends, neighbors, people who are in a loving relationship with the person receiving care, and on the other side of the equation, you also have care providers, the PSWs, DSWs, et cetera. You don't really get the one without the other. For the care system to work and for the circles of care to work, the two need to work hand in hand. And you really need to make it as easy as possible for those caregivers in the homes doing a lot of that frontline work and the day-to-day work. You need to make it as easy as possible for those caregivers to access the home care and the other care providers they would have access to. We hear from caregivers constantly about how hard it is to navigate these systems and get in the right doors, tell the same story 5 times, fill out the same form 7 times, only to be told that they are eligible for a meager amount of publicly supported home care or other sorts of home-based care provider work, that caregivers end up feeling sort of like, why did I bother? You know, there was a lot of work and angst that went into getting not much support at the other side. So I think that navigation piece is critical, and remembering in that spirit of one size certainly doesn't fit all, that these are people who are already overtaxed doing their care work for their loved one day to day. I recently just went through this with my grandfather, actually, where by the end of his life over the summer, we had, I think, 8 home care providers coming in and out of his home by pretty much every day. And just the navigation and coordination piece is in and of itself an almost full-time job, let alone the other demands on a caregiver. So navigation and ease of care and access of care is critical here.
So thank you for those reflections, James, and setting us up quite nicely for the next question, which I will direct at Paul to start. So how does improving client access? So we've been hearing that that's been a key issue, as well as the importance of navigation. So how does improving client access to appropriate supports and transitions through the system impact quality and safety of care that people receive? So Paul, you first.
Yeah, so I'll take to start off a little bit of a personal view. I am a caregiver. I have been a caregiver to 3 older adults, 2 of whom died during the pandemic, and 1 I continue to care for. And one of the things that I've noticed, and that is reflected in our research, is in fact that my role as a caregiver has changed. I was the son of the person I'm taking care of. Then I became the caregiver. Then I became a visitor to the care where my mother lives. And now I'm sort of an adjunct to that whole system of care. And so, you know, the transitions that I have had to undergo as a caregiver reflect the transitions that my mother has had to go through in the course of her journey with dementia and other things. And so when we step back and we think, you know, how could we improve this transition, and how could we improve the quality of life of the caregiver, but also the client in home care? One thing that we did is we asked people, so how do we fix this? We asked, particularly in the field of dementia, you know, caregivers of people living with dementia and clients and care providers, you know, what's missing? What could we add to this mix to make this better? And we heard that, you know, care providers have all the tools or have tools available for good person-centered care. And the relationship between the person living with dementia and their caregiver is one that's negotiated between them because they have a relationship. But the relationship between the care provider and the caregiver is not always clear. And so what we've developed is something called our Dementia Journey Journal, which is a way for the care providers, who may change over time. Let's hope there's less change than in the past, but they may change over time, and the role of the caregiver, so they can exchange information. Care provider who becomes a greater force in the person's life has more information on a day-to-day basis, can share that with the caregiver who is missing that day-to-day interaction. And the long-lived experience of the family member can be shared with the care provider, so they know when she says this, it means that, and that sort of thing. So we've created this, our Dementia Journey Journal, and hope to be offering it shortly broadly. But it's solving that problem of the transitions in roles, the transitions in health status, and also the feeling of clients and caregivers.
Great reflections, Paul. It is all about relationships. Over to you, Janice, to add in.
Yeah, I just wanted to add in, I think that's a wonderful idea. The having a booklet, and in my own caregiving journey, we did that with my mother, who had lots of children coming in and out, but just to have that reflection of how things were, what worked well today or not, and then some of the care providers to provide a little update for us as 9 children coming in and out. But the other thing I wanted to add too around the transitions, and this is some of the work that we've done in Nova Scotia and also in Manitoba, where we've looked at 10,000 different home care clients, followed them for a serious time as they interacted with the healthcare system to see where some of the gaps are. And being able to recognize that when someone goes into the hospital and then comes out again, what is has their home care services increased? So is someone like taking stock of some changes in their health system or health transitions, as well as are they getting access to the appropriate specialist services? So are they being referred to specialist services given what their particular incidence in hospital was? So being able to, I think it's really important at that local level, as Paul was talking, but also at a systems level to have those checks and balances of how to follow people and make sure that care planning and there's a revised assessment, there's a reaction to the needs that may have been triggered by hospitalization, I think needs to be added. Thanks.
Absolutely. Janice. James, over to you.
Yes, thank you. Here at the Canadian Centre for Caregiving Excellence, we put out a policy paper on all manner of caregiving issues back in November. If you'll pardon a shameless plug, I happen to have a copy here. It's called Giving Care. You can find it on our website, which perhaps the moderators in the background could share in the chat with the audience. One of the things we talk about in there is sort of along the lines, Janice, what you were saying, is around keeping in mind that at the end of the day, these are people with challenges and with things going on in their lives. So when you've got a person who needs care in a doctor's office and you've got their caregiver with them, say on a regular checkup visit, something like this, yes, of course, the attention of the medical professional should be on the patient, in this case, who also is a person receiving care. But why not also have a built-in automatic conversation with a caregiver who's there as well? Because nobody will know better than that caregiver what the realities are like at home, and what the person at the center of all this, the person receiving care, both what they need, but also what that caregiver needs in order to keep doing their essential care work out in the community. And the reality of life for many caregivers is you don't have a lot of time on your hands to keep reporting in and checking in and letting people know how you're doing. But maybe you've got an extra 5 minutes at the end of a doctor's appointment when you can have a conversation. And if team-based care and community-based healthcare does what it's supposed to do, that physician or that nurse practitioner, whoever it may be, also has the resources and the connections and maybe even a warm referral to get that caregiver what they need based on that conversation in the room. In other words, activate it right away rather than go through another application or intake process. We talk a lot about, the various practices around the world around these what can be called these mandatory assessments for caregivers. In those situations, you'll see some of that in our white paper, and there's some promising research around that stuff as well.
Go ahead, Jane.
Yeah, I just wanted to comment on that we often have to encourage clients and the caregivers to keep in regular contact with the family physician, because the family doctors are actually, I find, not well integrated into the home care system, right? They're really not. So we have we kind of put the onus on the client and caregiver to do that. What can be helpful about that as well is the physician or the nurse practitioner can actually become an effective advocate for the client and the family. I've seen people get a lot more additional home care because of the physicians, right? The physicians call, right? So, and there also means that there is another eye on the caregiver. And of course, the caregivers have to speak up. I encourage them, you have to be really forthright and really honest about the impact of the care on you.
So building on those two reflections, both from James and you, Jane. So then what supports can be built into the current home care environment to provide that psychological safety of caregiver and clients, to have those conversations, to make sure that they're able to access the care and the services that they need as they sort of navigate along these different pathways through the system? Jane, I'll start with you.
Okay. Well, I think an ideal is to provide fairly intensive case management, actually, that really links home care with the primary care provider, the physician or nurse practitioner, and all the other systems, right? Hospitals, community resources, long-term care. We all know, we've all been mentioning this, clients are often on their own to sort this out, and it's not something you can Google your way through to effectively. So I think case management, right, being very aware of all the community resources and services and working to remove any barriers to utilization, would be an important service, important improvement in home care.
Janice?
Yeah, that's that's really important. I would also add, and this is a little self-serving, but myself and my colleagues have developed a care tool called Caregivers, Aspirations, Realities, and Expectations. So this is an assessment of what the caregiver's needs are. So I think it's sort of parallel to what Jane is talking about around case management. We really, as we said at the beginning, like caregivers are unique individuals, and what works for you may not work for me in terms of what my needs are. And so I think we need to sit down with the caregivers and see what we can do as a society, as a home care support, to be able to support them. And so that to me is critically important. And the other thing I think is allowing them some flexibility in the way that services are delivered. So it's not, you have 2 hours here to get everything done. And similarly, we need more policies that are actually directed to caregivers and not just, and not to take away from the client, but without the caregiver, the whole situation is not going to necessarily help to be able to, I guess, have someone stay in the community. So we really need to recognize that these policies have to happen at the workplace. For some people, they have to happen at public services for others, maybe a financial benefit, they need to happen in a coordinated educational way. Like we need to be able to have these services almost like a welcome wagon. I know it's overwhelming at the beginning, but here's some options. Let's stay in touch and let's see what you need now, because it's changing as Paul really illustrated on your needs. You still need to understand what it's like to be a visitor versus what it's like to be a caregiver. And, you know, all of those things I think are important. I'll stop there.
Thank you for those reflections. Janice, over to you, Paul.
Yeah. So thanks, Janice. You triggered me into thinking about one of the basic issues in home care and in healthcare generally is that we've commoditized it. We've said, little chunks of help are good, nice and efficient. If we pay for each little chunk, we're going to get lots of each little chunks. And I think what we've all mentioned is it's about relationships. It's about creating the sphere of care that is flexible and that can be shared across a variety of people who are all trying to help out. And let's hope they all have the same goals. And so, one of the basic policy issues is about funding. Is it per visit, per procedure, or is it about the care of a person? And sort of home care is the ideal situation where providers are in somebody's home in their life, rather than being taken out of their homes, out of their lives, and having a procedure in a hospital. So home care is where we see the person's life, or we can see, and if we see that life and then reflect funding that allows us to help that person live their life, I think we're in a better place. But that's a significant policy issue. There are situations across Canada where we have sort of what's called bundled funding for sort of a periodic, flexible approach to care, but it's fairly limited. And it's, and to what I said at the beginning, the ability to actually create a bigger circle of care than just the nurse and the personal support worker, but also the physician and the physiotherapist and the optometrist and the barber and so funding is an essential issue to deal with.
So Jane, I know you raised your hand. I'll give the floor to James first, and then I'll loop back to you before we move on to the next question. So over to you, James.
Great. Thank you, Tanya. So many things to say there. The line that I say frequently, and we say frequently around here at the Canadian Centre for Caregiving Excellence, is that caregiving is the next frontier of public policy, in the sense that it's the next sort of crunchy big issue that we all collectively need to tackle for so many reasons, not the least of which is what Janice alluded to a moment ago, that none of this happens in a vacuum. You've got your care responsibilities for your loved ones, for your neighbor, your friend, your son, your daughter, whoever it might be, but you're also a worker, you're also a citizen, you're also somebody who needs to go to the grocery store, you have to pay your bills, you have to, your life doesn't come to a screeching halt when you've got care responsibilities in the moment. So a responsible public policy response is one that recognizes that this is happening every day, and there's a role for the state to step in to make it easier for people to be a caregiver out there and take on those responsibilities in addition to their day-to-day responsibilities that the rest of us have. And as in many things and stuff like this, I look to Scandinavia and I look to the UK, where their approach is, it doesn't really matter how you got to be a caregiver. We're not going to piecemeal you into what is it, aging, is it dementia, is it a path to long-term care, is it childhood disability, etc., but rather, okay, let's meet you where you are. You are a caregiver today. Here's a basket of services and a basket of supports. Here are things that you're more or less automatically entitled to just by virtue of putting your hand up as a caregiver, which, by the way, in the UK includes a financial benefit of about £400 a month to help ease the financial strain that happens, especially on the margins. And then once you're in, you're in. You don't have to keep reapplying, reassessing, and going through that rigmarole every time. So the only logical approach to make all this work more easily for people is to meet them where they are with a proper policy response that recognizes that this is a challenge both for today and for the future.
So Jane, over to you for the last reflection on this question.
Yeah, I completely agree, James. And just in terms of the context, I really need to bring my social work lens. I would say that we need to take into account the social determinants of health, and this affects the client and the caregiver. So we have issues of income, finances, housing, social support networks. All of these have a direct impact on the home care experiences, including, like, we're starting from how they feel about providers coming into their home environment, to their ability to heal, to recover, or, age in their homes.
Tanya, can I very quickly add one thing to what Jane just said?
Go
Just
ahead,
the
James.
social determinants of health.
Yep.
Actually, out of emerging research out of the UK and the US is actually starting to treat caregiving itself as a social determinant of health. That the fact of you being a caregiver has an automatic, predictable impact on your health in the same way that age, disability, socioeconomic status, etc. has. So some interesting emerging work there as well. Sorry, Tanya.
Oh, no, that's great. That's an interesting reflection to share. Thank you for sharing that, James. So just building on the concept that there is a bit of a pathway, and we've talked lots about transitions. So Paul, how does the home care system currently interact with the different parts, or not, with the different parts of the healthcare system, based on both that idea of the transitions and then on in your research and in your lived experience?
Yeah. So, overall, I think that there are, and I think we've all reflected on the distinct pillars or silos of the healthcare system. And they reflect, in some, sort of in our efficient world, they affect an efficient allocation of resources to different functions. What they don't reflect is sort of what I was talking about, is somebody's life. And how do we, so what's the balance that we can get there? And I think there are pockets across the country where there have been conscious decisions to link, say, hospitals with home care, where there's a crossover of people from home care into hospital into home, so that actually the providers overlap and understand the transition from the person's point of view, rather than the system's point of view, which is you're out of hospital, now you're in home, it's your responsibility, it's not mine anymore. So there are some examples of that. Again, they're not systemic or systematic, they're intentional. But I think that's the kind of thing where we need the crossover. One of the interesting things that seems to be starting in Ontario, but it's not clear that it's going to be sustained, is actually the embedding home care in primary care, or creating a very good close relationship there, so that the family doctor is not isolated from what's happening in the home, and what's happening in the home is not isolated from the physician, and the physician also has a view into what's happening in the hospital, and so on. So getting those, the potential for that integration, which it's natural. In a primary care setting, you're looking at somebody's lifelong health experience. In home care, it's a shorter period probably, but it's the same sort of perspective. So I think there's great promise for that, for a greater linkage there. And I don't know if other panelists have observed some potential there or in other places. Maybe I'm being too optimistic at the moment, but I think it's a genuine place to think about connections that we can actually link the system to James's point, in order that the people are served well.
And I think it's great to focus on those pockets of improvements, because I don't think we talk about them enough. So James, I believe you have your hands up, so I'm going to pass over to you.
And thank you, Tanya. And just to Paul's question there, so not to throw in another Ontario example, but in Ontario, we're in the middle of a transformation around healthcare towards family health teams, Ontario health teams, OHTs. away from a more regional model of care. So an OHT that is led by a large player in the system, like a hospital or even a family health team, et cetera, rather than an institutional government body. Leading that, it's underway in parts of the province. There and in some parts of Ontario where it started to be rolled out, Paul, along the lines that you're talking about, there has been some direct integration right at that level of that senior player of the local home care providers, and also both for-profit and not-for-profit home care providers at the table. So that has made it, certainly anecdotally still, because this is very early days, but it has made it possible for at least those providers to be at those tables where the resource allocation happens and where those pathways are mapped out, which I think in and of itself is a systemic improvement that hopefully will produce better results in the field.
That's a great example of some integration that's happening at the local level. So thank you so much for sharing. And then just building on that theme of opportunities for improvement and what's working well or has the potential to work well. Jane, I will ask you, when you look at the home care and transitions, including to long-term care, do you have any examples of what you've seen has been working well? Obviously there's probably some opportunities for improvement, and any advice you would have to share with regard to these specific transitions.
You know what? In the olden days, I think I'm old enough to say that. In the olden days, there used to be kind of a more expanded services in the home, like housekeeping. Like it used to be a service available. And, I can't count on the number of clients who's just like, how can I get some housekeeping, and often don't have the financial means to do that. But that your home environment has an impact on your well-being. I'm just going to give a quick anecdote because this one really stands in my mind. I remember leaving a home one time and I asked the man, is there anything else I can do before I go? I remember I'm in there as a social worker. He kind of sheepishly said, I would just love it if you wouldn't mind just dusting where my TV is, because that dust is really, really bothering me. And it's like, 5 minutes later, he's beaming, and it's probably had, I don't want to devalue my skills, but it probably had as much impact or greater impact than anything that came out of my mouth the hour before, right? So broadening what we're offering. And again, I'm going to harken back to the olden days where we had more like hospital at home type programs. I mean, there's the whole ALC issue, right? That had these weighted home programs that, in my experience, were really quite effective, right? So that people could have 24-hour care in the home to help with that, to be as part of that transition to long-term care. So those two things that kind of jump out for me.
Janice?
Yeah, maybe I'll do a Nova Scotia example, because I know that our health authority has really tried to identify situations where the client can be redirected perhaps out of hospital without being admitted to home, so called Home First. I can put the link in the chat for you, but this is really to circumvent I don't want to say unnecessary hospitalization, but to help focus and intensify, just as Jane was talking about, supportive services to mitigate an admission and a potential future nursing home entry. So just really focusing on investing some high-level nursing and care programs. I agree with Jane as well with the breadth of services that are offered within our program. So we still do have some homemaking services that are allowed as part of the home care package. I think we need to become much more aware of some of the equity and diversity issues that may limit or act as barriers for certain groups to be able to access to access home care. And I'll give you a quick example from our research of a client who had home care services during the pandemic, but was not able to, while they did meal preparation, the client had to have the food in the house, right? So the worker did not go to get the food. The groceries had to be purchased, and they would make the food. However, during the pandemic, the cost of home delivery of that food became much higher and not as accessible to a person on low income. And so consequently, they actually ended up canceling the meal preparation services that they were being offered because they couldn't afford to get their groceries delivered. So this sort of intersection, like just of different income levels. I know you've spoken before about health determinants, but also cultural expectations. Like, it is very complex, but I think it also needs to be addressed. So those two sort of things about, yes, we do need some more investment in helping people be restored at home. And we also need to recognize how our services, the way that they are organized, may impact different individuals or different clients differently depending on their own characteristics.
It's a good reflection, Janice, and actually links to one of the questions that we received through the chat about someone seeking advice for caregivers of older adults with dementia and mental health and addiction conditions that are deemed ineligible for home care services due to safety concerns for the providers. And so I guess I would ask, how do we set up a system that is actually accessible to those who need care and not excluding those based on certain conditions, or in that case, a financial situation? I don't know if someone wants to jump in first.
Yeah, I mean,
Go ahead,
I'll start.
Janice.
I'll start and just I'm happy to. I'm sure my colleagues are more in touch on the ground. I'm more of a researcher on this panel, but I do think that we do have, at least in our province, behavioral specialists. So it's very difficult to ascertain what the safety aspect is, but I think that's really an important question. Recognition that there are often interrelationships between dementia and mental health, and that having those individuals who can help home care workers to understand or navigate those situations and what are the best techniques for those. Sorry.
I think James put his hand up first, and then I'll go over to you, Paul.
Okay.
It was close, though.
Thank you, Tanya. That is such a tough one, because as they having until recently been a consumer of home care services for my grandfather, especially near the end of his life, where his dementia was getting harder and harder for the care team around him to work with. I know that can be very challenging, and again, as a consumer, my inclination is to say that's the job. This is tough work with people in very tough situations, often near the end of their lives. But that is from a place of frustration, having just gone through this in a very raw way not long ago. So which makes me think that the proper response then is you need to support the caregiver on the ground who is dealing with that situation, because you might not get to a proper, fully staffed care team with all of the care providers that you need because of those behaviors and because of the mental health. That's just a fact of life, for all the good reasons around workplace safety and everyone's entitlement to be safe in their workplace. Of course, that's a given. But then recognizing that extra effort can go into supporting that caregiver who by necessity will have to make up the difference. And that means real human contact. Like, you need a person who knows what they're doing to sit in that person's house with a cup of coffee or a glass of water or something, or maybe something even a bit stronger, and have that frank conversation and put real resources on the table there to make that situation as tenable and sustainable as possible.
It's a great strategy, James, is to focus on the caregiver. Paul, over to you.
Yeah, and so it's an interesting. Thanks, James. It's a good reflection, and I think one thing we can't abandon people. We can't abandon people, and so the alternatives that's offered most frequently is admission to long-term care for a person whose care can't be provided at home. Stepping back to the research I mentioned at the beginning, what we found when we compared sort of the profiles of people in home care and the profiles of people in long-term care, there is a fair overlap. There are lots of people with behavioral issues, cognitive issues, dementia, who are living at home safely and in a good way. There's a similar population in long-term care. And it is the kinds of things that James, you mentioned. We need to support the people at home to deal with these issues. We can't just say no. And so it may require more resources. It may require more training. It may require different kinds of people attending in the home, but we cannot give up on people. We cannot. We just cannot.
Jane, I believe you want to comment on that.
Oh, thank you. Absolutely, Paul. We cannot give up on them. And, essentially for, I think, caregivers, we need to provide dementia care training to caregivers, and we need to bring it to them, because there are a lot of well-researched, well-established techniques, strategies that work, right, for dementia care. It still becomes extraordinarily challenging. I don't want to minimize that, but there's training and there's care strategies that really are effective and work. And we need to bring those to the caregivers, because as you say, the bottom line is they're doing the lion's share of the care. They're our largest unpaid healthcare labor force.
So James, we've received a question in the chat just about how well equipped our current home care services are to address caregiver well-being burden through the different assessments that are done. And I'm wondering, can you please elaborate on the types of education and training that you can provide to support caregivers, or what else is available in response to that question?
Sure. So caregiver training, as Jane said, that is absolutely essential, because as Jane said, these are people who are doing the lion's share of the work anyway, regardless of how expensive the home care and care provider network around them may be. So you got to train them. There are the nuts and bolts of it all. The transfers, the moves, the changing of sheets, the changing of clothes, that kind of stuff. You need to do that stuff. That is sort of table stakes, if you will, if you're going to be the primary caregiver right in the home, because that is going to take that is going to take some of your time. But it is also worth thinking about this slightly one level up around the planning regime. So while you're doing that stuff right in the trenches, you also have to train the person to think a little bit more big picture about what happens next. How do I, as a caregiver, identify that I have reached the end of my rope, or I am nearing the end of my rope, and I need more help? And what are those avenues that are available to me? And lastly, there is an enormous unfilled need out there that we at the Canadian Centre for Caregiving Excellence are doing a little work around supporting out in the field around caregiver mental health and addressing caregiver burnout. That's the sort of third level of training, I would say. Call it resilience, call it burnout prevention, call it mental wellness. There are many different ways to describe it, but you need to think about these people again as people, with very stressful situations on the ground, where you need to learn the tactical stuff, the strategic stuff, and the bigger picture stuff. I'll make one push around a particular course that Donna Thompson, the great Donna Thompson, based out of Ottawa, has put together on caregiver training. You can find some stuff about that on our website. That's a great place to start. And it's sort of an integrated different skills along the way. Last thing I'll say is it also needs to be continuous, because your caregiver needs today are not the same as your caregiver needs in a month. So if you're in a situation where suddenly you need to learn how to do something more tricky, you need to be able to quickly access how to do it safely and reliably. Thanks.
Jane, you wanted to add on, and then Janice?
Yeah, just in terms of resources, I actually did want to do a plug for a couple that we have at SE Health. I mean, one in terms of the nuts and bolts, and I refer to this one a great deal. We have a caregiver platform called Liz. It's an online education and support platform. It has literally hundreds of articles and blogs on what we call all things caregiving. But embedded in that is what we have is a care channel. And that's where there's a number of videos, because people learn differently as well. But there's a number of videos that are really about the nuts and bolts. Like, how do I change a bed sheet when somebody's in the bed? Well, these are personal care workers that go to school to learn how to do this. What's effective pain management? Like very nuts and bolts kinds of skills which caregivers are asking for. And what I love about this resource, it's also in referring to your, Janice, the diversity inclusion issues. This is available in 5 different languages. We have this in English, in French, Spanish, Punjabi, and Mandarin. We also have caregiver coaches, what we call caregiver coaches, to help with the navigation piece that we've all spoke about the need for. So I just wanted to add those.
Janice?
Yeah, no, this is great. And I just want to say that we at my center, the Nova Scotia Center on Aging, we're actually working with 4 Caregivers Nova Scotia on providing some strategies to support caregivers in our province, looking at a whole host of different needs. And we also are doing a focus on education. And just as Jane and James have mentioned, it's amazing when you go to look at it, how many resources are out there on the internet, on the web, through colleges. Like some provinces have college hubs like Alberta, and excellent resources on James's website. We've been there. We went all across Canada and internationally looking at the different educational strategies for caregivers, and keeping in mind that we're here talking generally about all caregivers, regardless of whether there is a specific disease entity. But then when you get into certain areas like dementia, Alzheimer's Canada, different Alzheimer's societies, also, autism, cancer, these entities, these health foundations also have caregivers, caregiver education and training. And so, we're trying to figure out, and this is something that Caregivers Nova Scotia is leading on, is just what is the best way? And as James said, at what time? Because we know those needs shift. What is the best medium? Is it online, asynchronous, like go and do as you will? How do you manage to support caregivers to find the thing they need in this wealth of information? So, I think we're like, if someone ever said, we need a checklist, I'm like, there are thousands of checklists. What we need also is support, and we need to help. I think it was James that said we need to help caregivers by assessing their needs. We need them to talk about it as it affects them, and then so that they can figure out, is this affecting my own health? When am I going to have to stop providing this care? Because I think that's a whole other component, that we shouldn't be always given the assumption that people are going to continue. And when they reach out to home care and home care programs, it's usually because they feel they can't continue. So we just need to be really aware of that education is essentially important, but it has to come with some supportive services too. Thanks.
Thank you for that, Janice. I think there's consensus on the panel today that the caregiver is pivotal to providing better care, safe quality care at home where there's a caregiver present. And so absolutely, that is one key takeaway from today. So Paul, I'll start with you. Just thinking about the conversation we've had, we've talked about consistency on transitions and obviously the role of caregivers. And we've had lots of questions in the chat come up around the workforce and the roles of unions and how do we ensure a more stable workforce. So what would be the key takeaways that you want to leave people with today based on the research and your experience?
Yeah, so I think that, I think I mentioned advocating for different funding for home care to make it more flexible and responsive to individual needs. That doesn't necessarily mean more, it means better. Now, it may mean more. I'm not going to give away more, but it just is better and better organized and more continuous. Let's get away from the piecemeal delivery of home care and into something that cares for people's lives. So I think I would say that that's sort of emerged from our conversation today. So I'll leave it there.
Thank you. James, I'm going to go to you next.
Sure, thank you. I think this is one where I link arms with our brothers and sisters in the union movement on this thing and say you can't really even think about addressing this fundamental problem without talking about wages, right? Like the wages are just too low, and the workplace conditions are not appropriate around too much part-time work, not being, at least in Ontario and other places, not being paid for your travel time between client visits, that sort of thing, access to benefits, retirement savings, etc., all of which frankly are policy choices. That is a policy choice that has been made by a government of whatever stripe to pay X rather than Y, of course defined by fiscal constraints and other things, but the fact of the matter is it is in some large part about the fact that these are tough jobs. If you want people to do them and keep doing them as a career rather than just a job, you got to pay them well and make it possible for people to live a good quality of life while doing this essential work out in the field.
Thank you, James. Over to you, Jane, and then I'll give the last word to you, Janice, to wrap us up. So Jane first.
I don't really have anything to add. I agree. You have to look at this home care workforce and the needs within that and all the issues that James addressed. And what Paul said, we have to have a more flexible and responsive home care that addresses the needs of the caregiver and the client.
Janice, key takeaways from today's discussion?
Well, key takeaways, absolutely. Can't agree more that we need to support the workers with improved wages and benefits. We need to develop systems so there's more consistency of those workers from the perspective of the client. We need to put the caregiver also in the center with the client, because if they are there, we need not to assume that they are there, but we need to support them with tangible supports. We need to recognize that they're unique and different, and their situations are unique and different as well, and pay particular attention to the EDIA aspect of their work. And we need to recognize that caregiving isn't only of older people, that caregiving can be happening with children with special needs and have a whole other host of challenges and issues. So some of the things that I think as I think Paul mentioned early on, this isn't necessarily that cheap option. We need to see it as a value to help people to stay at home for as long as possible and get away from, oh, well, we're only doing this so they won't go into long-term care. That's not the way to look at it. It's about how do we support them in their environment to have the best quality of life that they deserve. Now I'll stop there.
Thank you, Janice. And I agree. Paul said, I think it's about life. It's about life care. And so I think that is definitely a key takeaway that I've heard today. And should be at the center of the conversation. So thank you so much to all of you today for this engaging conversation. I hope that our participants found it as equally engaging as I did. You will receive a follow-up email with the link to this recording that you can share with your colleagues and people who were not able to attend today. As well, you'll receive a blog summary of this episode that includes some additional insights on better home care for older adults and caregivers. And if you want to hear more about HEC, please sign up to our newsletter and you can find different ways to get involved. So thank you so much, Paul, Jane, Janice, and James, for this really engaging conversation. I feel like we're in a good place to do some great work over the coming years. Thank you so much.
Thank you, Tanya.
Thanks very much, everyone. Take care.